everyone, welcome to this explainer. Today we are unpacking a really fascinating academic conference presentation by Dr. Kim Ji-sung from Konyang University. We're going to break down the actual presentation slides and explore a genuine medical mystery surrounding the treatment of spasmodic dysphonia. We'll be looking at the hard data, comparing some wildly conflicting academic studies, and trying to figure out exactly how we should be treating this complex disorder. If you love a structured, evidence-based deep dive into medical controversies, you are absolutely in the right place. Let's get into it.
All right, so here is our roadmap for today. First, we'll quickly review the baseline of spasmodic dysphonia. Second, the Botox principle. Third, the voice therapy dilemma. Fourth, we'll dive into those conflicting academic studies. And finally, we'll look at the true role of voice therapy.
Section 1. Understanding spasmodic dysphonia. Before we can even begin to argue about the treatment, we've got to make sure we're on exactly the same page about the underlying problem. So as a quick refresher, the crucial point here is that SD isn't just a tired throat muscle, right? It's a focal dystonia of the larynx, meaning the brain is essentially misfiring. It's sending out these incorrect signals that cause involuntary muscle contractions in the vocal cords. It's fundamentally a central nervous system motor control issue, not a simple peripheral nerve problem. And because that root cause is central and neurological, well, there's currently no absolute cure. You can't just rest your voice for a week and expect it to magically heal.
Section 2. The principle of Botox treatment. Since there's no absolute cure, the medical community relies on managing the symptoms. Let's look at the gold standard. Take a look at this anatomy. It brilliantly illustrates the standard treatment. On the left, we're targeting the thyroarytenoid muscle, and over on the right, the posterior cricoarytenoid muscles. We are injecting botulinum toxin, Botox, directly into these tiny, incredibly complex laryngeal muscles. The goal here is chemical denervation. We're using the Botox to temporarily paralyze those specific muscles and basically put up a roadblock against those overactive, incorrect nerve signals coming from the brain.
But there's a catch, a big one. While Botox is amazingly effective at managing the symptoms and giving patients their voice back, it's inherently temporary. The body eventually processes the toxin, which means patients have to get repeated injections literally for the rest of their lives. Now, on the flip side, trying to use traditional voice therapy entirely on its own has massive limitations for SD. You simply cannot train away a central nervous system spasm with vocal exercises alone.
Section 3. The dilemma of voice therapy. So we're at a major crossroads here. Botox works, but it wears off. Voice therapy alone isn't enough. Which brings us to the big question driving Dr. Kim's presentation. If a patient gets a Botox injection and then immediately follows it up with rigorous voice therapy, does it actually extend the physical life of the Botox? Does it buy them more time before they need another needle in their throat? Or is the therapy doing something else entirely? Section 4. The conflicting studies. To answer this, we really need to look at the academic literature, and what we find is basically a scientific boxing match between two major studies. Here we go. Two highly respected studies, both published in the prestigious Journal of Voice. On the left, Murray and Woodson from 1995, and on the right, Silverman and colleagues from 2012. Both studies ask the exact same question. Does adding voice therapy to Botox actually help? But as we're about to see, they found vastly different things. Setting the stage, let's break down how they designed the research. Both studies had roughly 30 subjects, mostly female, which perfectly matches the typical demographic for SD. Both kicked off voice therapy about 3 weeks after the Botox injection for about 5 sessions. But look closely at that groups row. Murray, in 1995, just compared Botox alone versus Botox plus voice therapy at a single institution. Silverman, in 2012, took a much more rigorous approach. It was multi-institutional, and critically, they added a sham VT group, basically fake voice therapy, to see if just the psychological effect of getting attention was skewing the data. Okay, let's look at the results from that 1995 Murray study first. When they measured how long the Botox lasted, the results were staggering. The group that only got Botox had an effective duration of 14.9 weeks, but the group that added voice therapy, their duration skyrocketed to 27.4 weeks. Adding voice therapy nearly doubled the physical duration of the drug. For over a decade, this was basically accepted gospel. Do voice therapy and you won't need injections as often. But fast forward to 2012, when Silverman ran their rigorous multi-institutional study with the placebo group, the data completely flipped the script.
They found absolutely no statistically significant difference between the groups. In fact, and this is crazy, the group that received Botox alone actually lasted the longest, at over 22 weeks. The group that got the real voice therapy dropped to about 17 weeks. The placebo group was right in the middle at 20.4 weeks. So based on this conference presentation, we're left staring at a medical stalemate. The older data told us voice therapy was a magic bullet for extending the drug, but the newer, much more robust data from 2012 suggests nope, voice therapy does not magically make the physical Botox injection last longer in the muscle. There is zero clear physical advantage for drug duration.
Section 5, the true role of voice therapy. And this brings us to the most vital part of the explainer. Think about it. If voice therapy doesn't prolong the physical injection timeline, why on earth do we still prescribe it? Are we just wasting these patients' time? Well, we have to look at the whole patient, not just a spastic muscle. Because their voice cuts out, patients naturally try to force it, leading to severe compensatory laryngeal hyperfunction, which is basically extreme painful tension in the throat. This leads to chronic vocal fatigue, and honestly, perhaps most importantly, there's the immense emotional toll. The frustration, the sheer embarrassment of struggling to speak in public, it's absolutely devastating. This demands a total paradigm shift towards what the presentation calls indirect therapy. Voice therapy for these patients isn't about curing the spasm at all. It's about educating them on the physical mechanisms of their voice. It's about teaching vocal hygiene and preventing them from totally abusing their vocal cords out of sheer frustration. And crucially, it's about providing early, solid psychological and emotional support right from the moment of diagnosis. Voice therapy's true power, as highlighted perfectly in this academic breakdown, is relaxing that secondary hypertension. It's about maximizing the quality of the Botox effect we do have. It's about giving patients the mental resilience and the actual practical tools to face a lifelong chronic condition. When we support them emotionally and educationally, we dramatically improve their compliance with a really difficult ongoing treatment regimen. So I'm going to leave you with this thought to reflect on. In modern medicine, it is so easy to get completely caught up in the raw data of drug efficacy timelines. But when we step back and look beyond the strict half-life of a Botox injection, how much more impactful can holistic, supportive patient care truly be? Thank you so much for joining me in breaking down this incredible presentation. Keep questioning the data and stay curious.